A very good morning to Doctor and my fellow friends. Today, I would like to present my orthodontic case presentation. The orthodontic case presentation divided into two parts, which is Part A and Part B. Let's start with Part A, which is the orthodontic examination and diagnosis. For patient details, patient initial is NAR. She is 26 years old, Malay female, came with the chief complaint overlapping teeth. She is medically fit and healthy. Next, skeletal assessment. Skeletal assessment divided into three parts, which is antero-posterior, transverse skeletal relationship and vertical skeletal relationship. For antero-posterior, patient has class 1 skeletal pattern, straight facial profile. For transverse skeletal relationship, patient face is grossly symmetrical with competent lip. For vertical skeletal relationship, Frankfurt mandibular plane angle for the patient is moderate and she has increased lower anterior facial height. Next, intraoral examination. Oral hygiene of the patient is fair. The oral mucosa of the patient, no abnormalities detected. The gingiva is slightly inflamed. There is a presence of plaque-induced gingivitis and blunt interdental papilla. There is also caries detected on 4-6 disto-occlusal and buccal, 3-6 disto-occlusal, 1-6 disto-occlusal and 2-6 disto-occlusal. The teeth present in the patient is from 1-7 to 2-7 and from 3-7 to 4-7. The unerupted teeth is 1-3, 2-8, 4-8 and 3-8. The missing teeth is 1-8. For upper arch, the arch is in a U shape. For labial segment, there is a severe crowding on anterior labial segment. Bulge of unerupted 2-3 observed. 1-2 and 2-2 displaced palatally. 1-3 displaced buccally. 1-1, 1-2, 2-1 rotated distopalatally and 6-3 rotated mesiolabially. For the buccal segment, right and left are well aligned. For the lower arch, the arch is in a U shape. For labial segment, there is a moderate crowding on anterior labial segment. 4-1 displaced labially, 4-2 displaced lingually, 3-1 rotated mesiolingually and 4-3 rotated mesiolabially. For buccal segment, right are aligned with mild irregularities and on the left side is well aligned. Next, for interarch relationship, we divided into labial segment and buccal segment. For labial segment, the incisor classification is class 3 malocclusion. She has reduced overjet of 1 mm. She also has reduced atraumatic complete overbite of 10%. For anterior crossbite is between 1-2 and 4-2 and between 2-2 and 3-3. There is also posterior crossbite between 1-4, 1-5, 1-6 and 4-4, 4-5, 4-6. And there also presence of open bite between 1-3 and 4-3, 4-4 and between 6-3 which is the retained deciduous and 3-3 and 3-4. There is also lower midline shift to the right 2 mm and upper midline shift to the right 1 mm. For buccal segment, canine relationship on right side is class 2 half unit, on left side is unclassified because of the retained deciduous, and for molar relationship on right side is class 1, on left side is class 3 1/4 unit. The IOTN of the patient is 5I, which is the impeded eruption of 2-3 due to retention of 6-3. This is an orthopentamogram of the patient. The teeth present is from 1-7 to 2-7 and from 3-7 to 4-7. We can see tooth bud of 3-8, 4-8 and 2-8. There is also presence of tooth 6-3 retained in the arch. Tooth 2-3 is buccally impacted and tooth 1-8 are missing. There is no soft and hard tissue pathology detected. Next, for the lateral cephalometry assessment. This is a tracing done from the given cephalometry. As we can see, these are the results from the analysis. The SNA value of the patient is 89, which shows the maxilla is positioned anterior to cranial base. The SNB value is 87, which shows the mandible is positioned anterior to cranial base. The ANB value of the patient is 2, which is within the normal range of 2 to 4, which indicate patient has class 1 skeletal pattern. The SNMXP of the patient is 1, which is not in a normal range, so A and B correction cannot be applied. The MMPA, the maxillary mandibular plane angle of the patient is 29, which shows the inclination of the maxilla in relation to mandible is within the normal range. The UIMXP, the upper incisor angulation in relation to maxillary plane, is 115, which is in a normal range, so the inclination of upper incisor is normal. The LIMNP, the lower incisor angulation in relation to mandibular plane, which is 93, which is also in a normal range, so the inclination of lower incisor is in a normal. The interincisor angle is 123, which shows the angle between the long axis of upper incisor and lower incisor is within the normal range. The lower anterior facial height of the patient is 58, which is patient has increased lower anterior facial height. Summary of this case. Patient is 26 years old, Malay female, come with the chief complaint of overlapping teeth. She presented with class 1 skeletal pattern, straight facial profile with moderate FMPA and increased lower anterior facial height. There is severe crowding on upper arch and moderate crowding on lower arch. In occlusion, she presented with class 3 malocclusion with reduced overjet of 1 mm and reduced complete overbite of 10%. There is upper and lower midline shift to the right. She has anterior and posterior crossbite as well as anterior open bite. She presented with class 2 half unit canine relationship on the right, whereas unclassified on the left due to the unerupted canine. She also presented with class 1 molar relationship on the right, whereas class 3 1/4 unit on the left. Etiology of this case is dentoalveolar discrepancy, or also can be said as disproportion between tooth size and arch length, because narrow maxillary arch and broader mandibular lower arch, which result in a greater degree of crowding seen in the maxillary arch. For the problem list, there's severe crowding on upper and moderate crowding on lower arch, class 3 incisor relationship, reduced overjet of 1 mm, reduced atraumatic complete overbite of 10%, anterior crossbite between 1-1 and 4-2 and between 2-2 and 3-3, posterior crossbite between 1-4-1-5-1-6 and 4-4-4-5-4-6, anterior open bite between 1-3 and 4-3-4-4 and between 6-3 and 3-3-3-4, upper and lower midline shift to the right, class 2 half unit on the right canine and class 3 1/4 unit for the left molar. Impeded eruption of 2-3, retained deciduous 6-3 and carries on 1-6, 2-6, 3-6 and 4-6. The aim of the treatment is to relieve upper and lower crowding, to correct incisor relationship, to correct overbite and overjet, to eliminate anterior and posterior crossbite, to correct anterior open bite, to correct upper and lower midline shift, to correct right canine and left molar relationship, to class 1 relationship, to extract 6-3 and to expose unerupted 2-3 surgically, to restore caries on 1-6, 2-6, 3-6 and 4-6. For the treatment plan, we divided into general treatment and orthodontic treatment. For general treatment, we can do scaling and prophylaxis, oral hygiene instruction and oral hygiene education, which must be reinforced every visit. Restore 1-6, 2-6, 3-6 and 4-6. For orthodontic treatment plan, first we need to extract tooth 6-3, which is the retained deciduous, surgically open exposure of tooth 2-3. If failed, we can proceed with orthodontic traction and extract all fours on upper and lower arch to provide space. Fix appliance on upper and lower arch. Retention phase is retainer and review the patient. For part B, the question is, A 14-year-old girl came to the clinic complaining that she cannot bite properly. She presented with class 3 incisor relationship with reverse overjet of 2 mm and 40% overbite. Please design an appliance to correct her anterior crossbite. These are the intraoral photos that has been given. This is my design for upper removable appliance. I placed Z spring on tooth 11 and 21 and posterior bite plane from the tooth 141516 and 242526. There's a labial bow extending from 13 to 23 and there's a Adam clasp on both molars 26 and 16 and there is also acrylic base plate. For the justification for the component, for active component, Z spring on 11 and 21 is to procline the tooth 11 and 21. Another active component is posterior bite plane is to disengage the anterior occlusion to allow proclination of 11 and 21 by Z spring. Retentive component Adam clasp on 16 and 26 is act as a retention for the removable appliances. Next, labial bow is to prevent over-proclination of the tooth 11 and 21 and it also acts as a retentive component. Next, the acrylic base plate which acts as an anchorage for the teeth movement and act also as a major connector to incorporate all the components into the single functional unit. Thank you for lending your ears.